We're going to move on now to our keynote speaker, who's Dr. Robert Wachter, Bob. He's a professor and chair of the Department of Medicine at UCSF. Dr. Wachter is notable for many things besides being my department chair. He is the father of a whole specialty of medicine, hospitalism. The hospitalist is a doctor who practices only in the hospital at the highest acuity of medicine. Dr. Wachter has held many national leadership positions. He was a past president of the Society for Hospital Medicine, past chair of the American Board of Internal Medicine, a master of the American College of Physicians, I can go on, an elected member of the National Academy of Medicine as well. He is routinely on the list of the most influential physicians in America. I would say Bob has a real knack for communicating medicine and science to the lay public. It is such a valuable skill, one that's, I think, increasingly important in our days. During COVID, he was a voice of reason, expertise, and care as he hosted our Department of Medicine Grand Rounds, attended live and on YouTube by many thousands of doctors and laypersons alike. Perhaps you were one of them who was as reassured by his comments then as I was. As a master communicator, Bob has authored 300 articles and 6 books. His 2015 book, The Digital Doctor, he's known as the Digital Doctor, Hope, Hype, and Harm at the Dawn of Medicine's Computer Age, back in 2015, was a New York Times bestseller. Now, 11 years later, with absolutely impeccable timing, he's out with a new book, A Giant Leap, How AI is Transforming Healthcare and What That Means for Our Future. This book was an instant Amazon national bestseller, and we are excited and very privileged to hear from Dr. Wachter today. Thank you. Thanks, Bob.
Thank you, Ida. Thank you all for being here. Maya, I really appreciate the opportunity. This program is spectacular, very special, and really emblematic of what we can do together. It always struck me when I came to UCSF 40 years ago for what I thought was going to be 3 years, that it's wonderful to have a health sciences only campus, but there are things that we can't do in San Francisco that you folks at Berkeley are world class in, and the opportunity here to come together to work collaboratively on what to me is the most interesting and challenging topics probably in the world today, certainly in healthcare, I think is really remarkable. We are embarking on the greatest experiment in the history of medicine, I think, trying to figure out how to make this work and get it right. And to me, it's extraordinarily exciting, and there's no place better positioned to come up with the right answers than we are here. So I'm going to spend about 30, 35 minutes chatting with you, and then I think Ida and I are going to have a little talk to follow. I've called this From Novelty to Normalcy, AI and the Transformation of Healthcare. I think that is the stage that we're at. In the first few years, it was novelty. This is really cool. Tell me about Dr. Robert Wachter, but do it in the style of Shakespeare or the style of The Godfather. That was kind of fun. But now this is real. It's infiltrating our healthcare organizations and our entire system in ways that I don't think we've had time to truly think through all the implications. So I'm going to try to give you a sense of what I think some of those implications are. I have to say, when I thought about writing a book, and actually the idea came to me pretty soon after I tried ChatGPT the first time, and my wife, who's written 9 books, said, "Honey, you should really write a book about this." And I said, no, I don't think so. I think there are going to be 100 books about this. I think the minute it comes out, it's going to be out of date. And then about a month later, my publisher called me and said, you should write a book about this. And I said, what a great idea, which completely pissed off my wife. But what I recognized was the only way to get this right was not to focus on GPT 5.27 versus GPT 5.6, but rather to really try to helicopter up a level and think about what are the big issues that emerge when a technology that is this good, this smart, getting better as quickly as this is, hits a field like healthcare that is high stakes, that if we get it wrong, we can kill people, that is 20% of our GDP, that has a rich history, has powerful incumbents, including physicians. What are the big issues that emerge? And I'll spend my time here chatting with you about what I think some of those are. I'm going to have as one of the themes something that Eric Topol, many of you know Eric, who's actually proudly trained in medicine at UCSF and now is a world-class cardiologist and really big picture thinker about healthcare. Eric wrote one of the blurbs for the book, and this was his blurb. He called it an engaging, hype-free case for informed optimism. And I'm going to spend a fair amount of my time talking about how I landed in that place. If people might think, oh, are you just kind of an optimist and see things through rose-colored glasses? The book that Ida mentioned I wrote 10 years ago, which is really the story of the electronic health record, is a really grumpy book, is a really fairly negative book about how badly things went as we went from paper to digital and some of the surprising negative consequences. So I'm fully capable of seeing the world through a lens of pessimism, but I did land in a fairly optimistic place, and I'll spend a fair amount of time telling you why. Now, I've gotten a lot of nice reviews and a lot of nice feedback from the book, and it's been quite gratifying. One of the things people have told me, I spent a lot of time, I interviewed about 110 people to write the book, and a lot of those interviews were to try to find people and stories and quotes that brought the topics to life. And one of the things I've heard from folks is that a few people have said I couldn't put the book down, which is very nice and very gratifying. Here is one person who could put the book down. This is my granddaughter.
Hold the book.
So grab
Give me the book. We need the book.
There she is. Okay. But hopefully if you have a chance to look at it, you'll feel not like her, but compelled. I'm going to talk about optimism, why I got there, this issue of from novelty to normalcy and some of the ways we're actually using these tools today, and healthcare is notoriously slow to adopt broad digital tools, and we know that from the electronic health record, where we implemented EHRs 20 years after most industries had gone from paper storage of their work to digital storage of their work, and we only did it after the federal government bribed us to do it. So we tend not to be early adopters, but in this area, in this field of the new AI, we are. Some of the implications for leaders, and then I'll just give you a few short takes on some things that I think are particularly interesting. Now, my optimism, I should say, is really confined to healthcare. I worry, as most Americans do, about AI in the rest of our lives. I think if we hit 15 or 20% unemployment, we'll have a revolution. I worry about climate. I worry about bioterrorism. I worry about all of it the same way probably all of you do. But in healthcare, and I'll tell you why, I, and it turns out the public, have a different view of AI with much more optimism. This is a Gallup poll that came out a year ago, where people were asked, are you positive about AI? That's green. Are you negative about AI? That's orange. And you see overwhelmingly orange, negative, in the spread of false information, social connections between people, good jobs, national security. The only area where people had a generally positive view was in medicine. And so that I kind of landed in the same place, and here's why. I asked Nano Banana, this is the image-making tool in Gemini, to put together a graphic of somebody being optimistic, and the reasons for optimism are the combination of generative AI's novel capabilities, but also how badly broken the healthcare system is, and why in some way there's only one place to go, and that's up. And I think it's really the combination of those two forces that landed me in an optimistic place. I'll sort of give you a little bit more detail on that. Let's start with some of the novel capabilities of AI. You're all aware of this, but I kind of want to trace through my own evolution as I was looking over the shoulder of this AI, and was increasingly wowed and to some extent gobsmacked by some of the things that it could do. Capabilities that I'd been waiting for 20 years as someone following digital transformation pretty carefully, but were really not available until basically November 30th, 2022, when ChatGPT was released, and we all saw, wow, you can speak to this or write in it in plain English prompts, and it gives you an answer that a trusted colleague might give you, except for the hallucinations, of course. And that was a moment when I first used it that was saying, this is pretty incredible, and it has capabilities unlike anything we'd seen before, and to some extent capabilities that are really quite in sync with some of the needs of medicine, because so much of our data is stored in the form of narratives. So much of the information we get is in the form of conversation, doctors or other clinicians talking to patients, me talking to a consultant. All of those things couldn't really be analyzed or influenced in any way by prior technologies, whereas LLMs and generative AI provided new technology that could do that. All right, so then I said, okay, this is pretty cool. I wonder what its application is for healthcare. And then about a year later, studies started coming out showing that it could do very well on healthcare licensing exams, on healthcare board exams. So it could pass tests, the tests that we put doctors through to demonstrate that they have the knowledge and to some extent the skills and attitudes to be practicing clinicians. I said, that's fine, but that's, those are passing tests, answering questions. How about real tough cases, the kinds of ones that, when I'm on the wards, we grapple with, we chew on, complicated, multifaceted, no real answer in any textbook. And later that year, studies started coming out saying AI could do those pretty well too. They gave it the toughest cases, like the ones in the New England Journal, and it did at least as well as the best faculty experts. So now, as a human kind of rooting for the humans, including I've got a daughter and son-in-law who are pulmonary fellows in my program, and the idea that AI will be better than human doctors is in some ways profoundly upsetting. And so I kind of said, all right, it's pretty smart and it can handle a case, but what about empathy? What about the uniquely human skill of being empathic, communicating effectively? That's something that AI can't do. And of course, within a year, there were demonstrations that AI can do that too. Obviously, it has no empathy, but it can fake it as well as, and in some cases, better than humans. And then, clearly the world is going to be one in which the way we do medicine is going to be some to-be-defined collaboration between the humans and the AI, and there's a long history in informatics of humans are good at things, technology is good at things, but the combination is better than either one alone. That is sort of a fundamental paradigm of at least clinical informatics for the last 20 or 30 years, and then a study came out about a year and a half ago, and you all remember this study that said the physicians did reasonably well on a study of diagnostic reasoning. The humans with the AI did a little bit better, but the best of all was the AI by itself. In other words, in this case, the human in the loop served only to muck things up, which of course was increasingly upsetting for those of you rooting for the humans. And this is me, and my learning curve over the course of those 3 years was flat, and that's being generous given my age. So AI is getting better and better every day, and the humans are not. And so as we try to navigate our relationship and what it can do, what it can't do, what the role of the humans is, it's increasingly complex to try to figure out how does this all fit together. Now, AI is not perfect, and in the first year we saw many missteps, things that in some ways became caricatures. Here's one. When you asked Gemini how to keep the cheese from sliding off your pizza, it would suggest that you put glue on. Now, to be fair to Gemini, it did say non-toxic glue, but nevertheless, it doesn't sound like a great idea. When you asked it about how to improve your nutrition, it recommended you eat a small rock per day. So things that were obviously completely silly, wrong, and AI had a unique ability not only to give you a wrong answer periodically, but to bathe it in a lot of text that made it sound like it was authoritative, it knew what it was talking about. And so this term hallucinations came into common parlance and made many people feel like, all right, this thing is sort of fun, but never going to be ready for prime time in a high-stakes field where we can hurt people like medicine. I would say there are a number of harms and potential harms in the new AI, and this is my own personal scorecard. You, I'm sure, have your own, but it's important, I think, for us to reflect on the amazing things that this AI can do, but also some of the problems and get a sense of where it is and whether it's changing. And I think hallucinations and just general trustworthiness are substantially better than they were 3 years ago. And I think if you played with AI 3 years ago and say this will never be ready for prime time in medicine, it's really important to come back again today because it's very different than it was. Still not perfect, but markedly improved. A lot of concern about biases when it came out. Obviously, the current political climate is having an impact and some pushback against bias being kind of a dominant theme of the early years of AI. And I mean, I think it's an open question, but the biases in AI really reflect human biases, and it may turn out to be easier to make the AI better than to make the humans better. A lot of concern in the early days, and a lot from computer scientists, about explainability, that humans will never trust the answers from AI because it doesn't explain its work. I think a couple of things have shifted there. One is the new reasoning models can generally explain their work and do it fairly credibly. And the second is, I can tell you as a practicing physician, and I will admit to you, I have no idea how Tylenol works. No idea how anesthesia works. I use them because I'm pretty sure they work. There's a lot of stuff that we do that we can't explain. We just believe the empirical evidence that they work. In many cases, at least generally trusted regulator like the FDA has blessed that practice. And it turns out, I think explainability is less important than we thought at first. I'd say the two areas I'm most concerned about, obviously privacy and security issues are growing concerns. More and more patients are taking their entire medical record and loading it into ChatGPT with the promise from OpenAI that they will treat it confidentially. You have to believe them because they don't operate under HIPAA the way electronic health record vendors do. And obviously the more AI gets blended into clinical decision-making, making diagnosis, or gets loaded into your pacemaker, your insulin pump, the more the prospect of somebody hacking into it or putting in data that changes what the algorithm puts out, the more scary that is, the more it's embedded in surgical tools that are influencing what a surgeon does and where a surgeon cuts. Obviously, as the stakes grow, the concerns about privacy and security do grow. And the biggest concern of all I have is mis and disinformation and the fact that it is literally impossible to tell, watching someone speak or listening to what they say, a deep fake can come in and there's no way that humans can tell the difference between what's real and what's fake. I tried to give you an example of this. This is a picture of me sitting rounding in the ICU a few years ago. And I asked, I think this was also a Gemini, to create a deep fake, and we'll see what it does.
Don't listen to him. Deep fakes are nothing to worry about.
So that's really creepy. Doesn't sound like my voice, but that is me saying that deep fakes are nothing to worry about, a real easy thing to do, produce this in 10 seconds. So I'd say that's my biggest concern as we go forward. A couple more points about the amazing things that AI can do as we think about their application in healthcare. This is Ethan Mollick. If you are interested in AI meets work generally in other industries, he doesn't really write about healthcare, but and the progression of AI tools, I recommend you read Ethan. He's a professor at Wharton at the University of Pennsylvania. This is his book from a couple of years ago, which is terrific. His Substack is fantastic. And it's my way of keeping up with the tools and the workplace. One of Ethan's rules from his book is assume that the AI you're using today is the worst you will ever use. I think it's a reasonable assumption going forward. This thing is changing so quickly that it's important to recognize when you see a flaw today, there's a decent chance that it will be better, the AI will be better a few months from now. And finally, I guess the last point, and one that was one of the defining kind of theses of my book, well, actually, let me get back to that in a sec, sorry. The second reason I landed in this optimistic place is healthcare's need for transformation. So I've told you about sort of how good the tools are, that they're getting better, that they've demonstrated how good they are. But healthcare's need for transformation, I think, is in some ways a dominant theme and one of the things that distinguishes us from other fields. So I'll take you back to November 29th, 2022, not that long ago, when I tried GPT. The next day I would try GPT the first time. That day before I tried GPT, I wasn't thinking that I needed a better search tool than Google. In fact, I don't have that much of an imagination. I couldn't imagine a better search tool than Google. It seemed like Google was the epitome of search. You put in a question you had, and it came out with a series of links, and that seemed like what could possibly be better than that. Yet the minute I tried ChatGPT, I said, oh my God, this is better. I can put in a full text, pretty complex description of what I'm searching for, and it gives me an answer in plain English. That's a better form function than what Google could do. And yet, healthcare needs AI. I don't think anybody on November 29th, 2022 said, the healthcare system is just perfect. I can't imagine a better healthcare system. I know no patient who said that. I know no doctor, nurse, healthcare administrator, government official who said the healthcare system is optimal, firing on all cylinders. Everybody who was being thoughtful about this understood the needs of the healthcare system and understood that in many ways they were unaddressable without a tool like the kinds that are available now with generative AI. Just a couple of examples. This is a picture drawn by a 6 or 7-year-old girl now, a decade ago, after visiting the pediatrician, and later published in JAMA. And here she is there. Here's mom. Here's her sister. This is her recollection of the visit to the doctor. That's the doctor over there in the corner. She recalled the doctor sitting with his back to the patient and her mother typing away. The picture's magnificent, only for one flaw, that's the smile on the doctor's face. I know of no doctor who was happy being turned into a very expensive, grumpy data entry clerk, but that's what the electronic health record did to us. This is a problem that now is being fixed to a large degree by AI, which now can record a conversation between doctor and patient and create a properly formatted note. It's become sort of the first major use case for AI. Here's another study that came out fairly recently. I love the title, Call Me Dr. Ishmael. The study showed that 1 out of 5 patients has a medical record longer than Moby Dick. If you've forgotten middle school, Moby Dick is 600 pages. So the idea that in the 2 minutes that I have before I see a patient, I can review 600 pages of past record and figure out all the salient points is a joke. It's a cruel joke on me, on the patient. Can't possibly work. AI now has the ability to summarize that. Not perfectly, but certainly I can't do that perfectly in the 2 or 3 minutes I have. So this is just a couple of examples. Another one is there are 7,000 new medical research articles published every month. Obviously, there's no way a human can keep up with the emerging medical literature. So lots of things that the system has created that can't possibly be dealt with by humans, and our go-to solution for the last 20 years has been to hire more humans, nurse practitioners, PAs, the billing department, the call center. We can't afford that, and in many cases, we can't even find the humans anymore. So AI, the new AI, feels pretty well suited to solve some of the problems that I think were insoluble before it. And then the sort of final thought, and one that really is a thread through my entire book and the way I think about this. This is a favorite quote that Joe Biden liked to say. He would say, "Don't compare me to the almighty, compare me to the alternative." So when we think about AI summarizing a chart or drafting a note or suggesting a diagnosis or even providing mental health assistance to people, I think it's important and very hard to do with the technology, but important to try to do apples-to-apples comparisons and not compare the output to some mythical state of perfection, which we do not have in our healthcare system, but to compare it to the status quo and try to understand, is it better than the status quo? And that's a very hard thing to do with technology. We tend to hold it to a much higher standard. We know this with Waymo, because Waymo is demonstrably safer than human drivers. Waymos have driven over 100 million miles without a human fatality. And then 3 or 4 months ago, Waymo ran over a little kitty cat, and it became front page news throughout the world about Waymo having run over this cat. How many Uber drivers run over cats? How many of you have driven over cats? I mean, there's a tendency to hold the technology to a very, very high standard. Much of that understandable, but it's important to think about the status quo of healthcare and how much room for improvement there is. A couple of minutes on sort of novelty to normalcy. What is happening today? This is at UCSF. Every clinician has access to an AI scribe, massively popular. Every clinician now has access to AI chart summarization, AI drafting discharge summaries. The results seem to be good, also seem to be quite popular. Back office AI happening, and assistance in billing and coding, contacting patients that are due for a colonoscopy or a mammogram, those sorts of things. And clinical decision support, which to me is the ball game here, is starting slowly and not embedded in a meaningful way into our electronic health record. I'll talk more about that in a few minutes, but gaining lots of momentum. And to me, that is maybe the most interesting future direction here. What we've seen so far in our healthcare system and many others is we've started with low-hanging fruit. We've started with AI scribes to document a note or to review a chart. Terrific. I mean, and I actually quite sensible and politically sensible. You don't want to start with the hardest problems that when you screw up and kill somebody, that's the end of AI meets healthcare. That is we ran over the cat. You start with the small bore problems, you get experience, successes, win over the hearts and minds of the incumbents, and that then paves the way for more ambitious use cases and ones where the risk is higher. I think that's all quite smart. I think we're doing it the right way. But those are singles. The home run is clinical decision support. And there's an old saying in healthcare, the most expensive piece of technology in a healthcare system is the physician's pen. That's because physicians' salaries represent about 10% of healthcare costs, but decisions that physicians make represent about 80% of healthcare costs. The decision to use drug A versus drug B, get a PET scan versus an ultrasound, that's where the money is and that's where the clinical impact is. It's no longer the physician's pen, of course, it's the keyboard. The tool that we're essentially all using these days is open evidence, which didn't exist a few years ago, but it has demonstrated how applying the new AI to the medical literature in a thoughtful way just sort of within 6 months became the go-to tool for everybody, I can tell you, at least in the medical service at UCSF. And why is it better than prior tools? Because you can give it a complex query. If the old tools, for example, Up to Date, which was the best electronic textbook we had, you could say, what is the right dose of apixaban for a patient with pulmonary embolism? These tools, you can say, I have an 82-year-old patient with CLL, comes in with a fever, shortness of breath, an elevated white count, a creatinine of 2.7, and an infiltrate on chest x-ray. What do you think is going on? You put that into any prior tool, and it would just sputter. It had no idea what you're talking about. These tools will give you a cogent answer and now give you the references from whence it found the answer. So there's a reason this company is now valued at $12 billion by the market. It's really taken over. A couple of comments on kind of some of the things I think big picture thoughts to have as you think about this technology. We've already mentioned the idea of the human-AI collaboration being so central to this and being kind of a little bit less predictable than we thought. Here's how I think about this challenge, and I think it's one of the areas that we really have to understand much better than we do now. If AI was correct half the time, it would be worthless, whether it's suggesting a diagnosis, drafting a chart, because you wouldn't be able to trust it at all. You'd have to spend so much time reading over its results and correcting them that you would never use them. If the AI was correct 100% of the time, that's pretty spiffy. We would use it. We would eventually jettison the humans, because the human in the loop could only degrade the performance if it's right 100% of the time. I don't know what any of us are going to do for a living. I'm old enough and I play golf, so it's probably okay for me. But for the rest of the professions, I have no idea what's going to happen if the AI is correct 100% of the time in lots and lots of use cases in medicine. In some ways, luckily, neither one of these things are going to be true for the foreseeable future in most of the areas. What's going to be true will be the AI will be correct often enough to be useful, but not often enough to be perfect and to be entirely trusted. So we will set up these human-AI dyads, co-pilot, augmented intelligence, whatever you like. Sorry about that. I thought I turned you off. And that sounds like a very reliable, trustworthy system. The AI does its thing, and then the human becomes the final arbiter. The problem is it's less trustworthy than we think it is. One reason is the study I told you earlier. You can imagine a world where the AI is good enough that the human intervention degrades its overall performance, and that could happen. If the AI is right reading a mammogram 99% of the time, and we say, but the human has to do the final read, there's a decent chance the human will make the output less reliable. But there are other reasons. If you look at the strengths of humans, one of them is not being reliable when we're trying to be vigilant, overseeing the result of a technology that we've generally come to trust. It's actually something we stink at. If the technology has given you the right diagnosis or drafted the note correctly 30 times in a row, how carefully are you looking time 31? If you're human, the answer is not very much. And so that is a problem as the technology gets better. But I'd say the bigger problem, and one that requires a fair amount of thought and oversight and I think research, is the issue of deskilling. That in general, the humans may have been quite good at that skill in the beginning and therefore quite good at looking over the result of the AI. But as the AI gets better, the humans will get less good at the task. That's a natural progression. That may be fine if the AI truly takes over the task. I don't know how to read a map anymore, but that's fine. I guess if the electrical grid goes out, I'll be screwed. But by and large, it's fine. I do not remember my wife's cell phone number. I assume that I'll be able to find it in my phone, but if I lose my phone, I might never see her again. Those are things that could happen. But by and large, we accept certain kinds of deskilling. But in a world where we are asking the humans to be vigilant and trustworthy co-pilots with the AI, deskilling, or the AI is not ubiquitous or in some ways patchy. Deskilling is potentially problematic. It's happened in aviation. Now that That said, aviation is markedly safer than it was 20 years ago, probably because of technology, but there have been certain high-profile accidents where the technology went out, the humans had to do something that in the old days they would have been quite good at and no longer are good at it. This is the famous crash of Air France 447 off the coast of Brazil. Now 16, 17 years ago. The technology went out, they were flying through a squall, and the pilots did precisely the wrong thing. And I interviewed Captain Sullenberger, who coincidentally landed his plane on the Hudson the same year. And I said, Sully, what do you think happened here? And he said the pilots were flying a plane they were not familiar with. They only knew how to fly the plane if the technology was giving them the assist. As the technology failed, they did not know how to do that. This is a huge challenge in medical education as the technology gets better. We have now the first indication from a study that this is a real problem. This is a study from last year where experienced gastroenterologists who've been doing the procedure for 10 years on average were given access to AI colonoscopy, puts a nice little box around these precancerous lesions. They had that augmentation for 3 months, then they turned it off, and the performance of the gastroenterologist in finding these precancerous lesions fell significantly from what it had been before they had this experience. So just 3 months of exposure to AI degraded their overall performance without AI. It's a big conundrum to think through, and it's not just medicine. It's, what happens to your writing skill when you instinctively use Claude to help you draft something. You're probably going to get less good at it over time. But something we really have to grapple with, and I think CPH can be a really important organization thinking through some of these tricky issues. Maybe I'm going to end with this, and there are a few other things, but I want to be sure we have time to chat. As we think, I've spoken mostly about AI in the hands of experts, in being integrated into UCSF health system, being used by doctors or nurses or other health professionals. But in some ways, maybe the most important thing going on today in AI meets healthcare is the millions and millions and millions of patients using AI to get healthcare guidance. The number, ChatGPT just published some results saying last year 16% of people were using GPT for health guidance. This year it's twice that, 33%. Google and Gemini are getting hundreds of millions of searches a day asking for health advice. One of the things I learned in writing the book, I remember talking to Peter Lee, who runs research for Microsoft, and I said, these tools are really good. They're kind of amazing. I'm beginning to use a tool like Open Evidence for helping with diagnoses and treatment suggestions. And in some ways, I was extrapolating how useful they would be for patients. And Peter said, you really have to be careful to not assume that a use of a tool by a novice is the same as the use of a tool by an expert. And I think that's actually a really important thought to have as we go forward here. The expert can take, a patient might have 200 pieces of data. This morning I woke up with a sore throat, but I also have a history of cancer and I'm on immunosuppressives and my mother had, heart attack when she was 40 and I'm on these drugs and I'm allergic to this. Can take 200 facts and distill it down into a prompt like the one I just gave you, like the 6 or 7 salient facts. Patients have no ability to do that. There's no reason they should. Experts can also take the output of an LLM or AI and say, oh, that's really smart. I hadn't thought of that. I'm glad I used it. And that's kind of ridiculous. I'm not going to pay any attention to that. And again, novices, patients have no ability to do that. And so the tools that are going to be, and we've seen a few studies recently, including this one in Nature Medicine from Oxford, that showed how poor these tools are performing when patients use them. And the interesting thing about this study was when you took the prompt that they created and put it directly into GPT, in other words, no human in the loop, it did quite well. It was right about 90% of the time in terms of making the diagnosis. But when you gave the prompt to the patient and said, take that prompt and now interact with GPT, the performance degraded down to about 40%. So the human in the loop in this case really mucked things up. And what happened? Well, the prompt might say, patient woke up this morning with the worst headache of her life. Those of you who are doctors or other clinicians know that the worst headache of your life is a term of art. Like we learn in first year medical school, worst headache of your life, that is a subarachnoid hemorrhage. Until proven otherwise, do not pass go right to the ER because this could be life-threatening. if you put that prompt into GPT, it knew all that. It said, go to the ER, I'm worried about it being subarachnoid hemorrhage, maybe meningitis, but particularly subarachnoid hemorrhage. When you gave it to a patient, what the patients often did was say, oh, that's interesting, and they put into the prompt, I woke up today and I have a bad headache. And GPT would say, oh, I'm so sorry to hear, it's the usual sycophantic thing. Oh, so sorry. What you should do is stay home, take some Tylenol, turn out the lights. That is interesting and really quite important. The tools that are going to be useful for patients are going to be ones that understand that. They're much more iterative, act much more like a good clinician. You say you have a headache, it will ask you a whole bunch of appropriate questions before it goes ahead and gives an answer. Now, one of the challenges in medical education, and here are experts trained on creating scripts, vetting data, being able to interpret the outputs. And this is the final thought I'll leave you with, which is medical students begin life as novices, and we, on a good day, turn them into experts. And one of the biggest sources of debate in the world of medical education is how much stuff do medical students now need to learn? Because why do they have to learn all those facts and all that diagnostic reasoning? Haven't you tried open evidence, how good it is? They don't have to learn this stuff. Well, if they don't, they are still novices. And they'll probably act more like novices than experts. So my belief is, and it's really the hottest question in medical education, is that they still need to learn a lot of stuff. When I chaired a big conference on MedEd meets AI last year, and there was general agreement on removing one thing from the curriculum. Maybe the docs here will know what it is. It's the Krebs cycle. That's like the only thing, this little sort of thing in organic chemistry that I still have PTSD 40 years ago, that we never use again. But I do think it would be a mistake to take too much off the plate. So with that, why don't I stop? As I said, I think this is the greatest experiment in the history of medicine. I landed in an optimistic place because the tools are incredibly good, but largely because the healthcare system is so broken that I think we need them. But there's lots of opportunity for improvement and some opportunity for peril here. And I think, like all of you sitting at this interface, have the opportunity to really educate us, do the research that we need to get this right. So thank you so much for your attention. Appreciate it.